Assalamu alaikum. I am Dr. Bakhtawa. My topic of presentation is upper urinary tract drainage, and the session will be moderated by Dr. Faisal. So today we will discuss about the percutaneous drainage tubes, uretic stent, and ureterostomies. Our main focus will be on the percutaneous drainage tubes and uretic stent, as ureterostomies will be discussed in other sessions. So what are the percutaneous nephrostomy tubes? And they are tubes which are widely used for interventional procedures for the upper urinary tract drainage and decompression of the renal collecting system. Goodwin et al. First reported placement of percutaneous trocar nephrostomy in a hydronephrotic kidney. So can anyone tell about the indications? What are the indications of placing percutaneous nephrostomy tubes? Okay, so we will. Okay, so broadly, the indications are broadly classified into 4 indications. First is the relief of urinary obstruction in pyonephrotic kidney, acute renal failure, or intractable pain due to obstruction. For diagnostic testing, such as antegrade pylography or urethral perfusion test, such as Whitaker's test, and urinary diversion, traumatic or iatrogenic urethral injury, inflammatory or malignant urinary fistulas, assist of the therapeutic intervention like stone removal, we do PCNL, and dilatation or stenting of a urethral stricture, endopilotomy, foreign body retrieval, urethral occlusion for urinary fistula, tumor fulguration, delivery of medications and chemotherapy, and biopsy of a urethral lesion. So, few words about Whitaker test. So, correctly told by Dr. Hamza, Whitaker test is a upper tract geodynamic perfusion pressure studies. And this we do it nowadays. It is absolute. We do make 3 scan. Previously, it was used to detect the obstruction in the upper urinary tract system. So there are 2 transducer, one in the kidney, one catheter in the kidney, and other through in the bladder. And we infuse water at 10 ml per second per minute, and then we check the pressures. So if the pressures are below 13 centimeter of water, then they are normal. And if they are between 14 to 22 centimeter of water, then it's equivocal. We can go for further tests such as antegrade or retrograde pyelogram. And if it is more than 22 centimeter of water, then it suggests there is obstruction in the system. It's like T half in the MEG3 scan.
So why the rate of infusion is kept at 5 to 10 ml per second? Can anybody tell us why we cannot fill it with the 15 ml per minute? It will be more easy and it can be done more easily. So why it is kept on 5 to 10 ml per minute? Basically, the urine flow rate from the pelvis to the bladder, the pelvis of the kidney to the bladder is around 5 ml per minute. So we have to fill the system at the physiological rate so that we can get the equivocal results. If we will fill it more, if we can say that 15 ml to 20 ml per minute, so obviously the system which has the capacity to deliver the urine from the pelvis to the bladder is around 5 to 10 ml. So the result will be mismatched, and we can diagnose the case wrongly.
So we can also divide it into absolute and relative contraindication. Absolute is uncontrolled bleeding diathesis, and relative are uncooperative patient, severe despite distress, or surgical site infection or abscess. So what are the properties of ideal nephrostomy tube? It should be biocompatible, easy to insert, has good flow characteristics, and resistant to infection, incrustation, and dislodgement, and does not induce symptoms. So we have different types of design available for nephrostomy tubes. They are broadly, we can say that we have balloon catheters, Millicoat catheter, Cope catheter, nephroureteral stent, and circle catheter. In balloon catheter, again, we have Councilman catheter, Kai tamponade catheter, and Foley's catheter. So in Councilman catheter, it can be used for transurethral as well as nephrostomy tube. It has an opening at its tip. So through this tip, through this hole, we can insert guide wire and we can change frequently the catheter. And they are available in 16 to 24 FRs. Okay, Chi tamponade is the name indicates tamponade balloon. It has two parts, balloon at its end and a rod which gives drainage. The balloon gives tamponade effect when there is hematuria. Post PCNL, we can place this Chi tamponade balloon catheter, balloon nephrostomy tube. Foley's catheter, we place Foley's catheter after surgeries. Can anyone tell me in which procedure we use here Foley's catheter is nephrostomy tube? Yes, open pyelolithotomy. So when do we place Foley's catheter in open pyelolithotomy? We see in our daily practice. And what else?
So when the stone is not fully cleared, why we should place nephrostomy? We can place DJ stent. Why nephrostomy? As a sorry, Follies as a nephrostomy.
Yes, when there is bleeding, we can use this balloon Foley's catheter to give tamponade effect, as we don't have other catheters, our other PCN available, so we place Foley's catheter in other. What else indication? When there is pus, we also use Foley's catheter as PCN when we see pus in the, when we are doing pyelolithotomy and there is pus in the system, so we place.
And also when we anticipate any distal obstruction, when we cannot be able to pass DJ stent and we think that we have to perform antegrade study later on to just know about the lower tract, the lower part of the ureter, so we can place nephrostomy.
Millicoat catheters. Millicoat catheters has wings at its tip, so it provide a modest and a traumatic non-obstructive retention mechanism. And they are large bore catheters ranging from 16 to 30 French. So these have good mechanism of retention. So they are usually placed in frail or mentally challenged patients, so they cannot pull out their nephrostomy tube. And when there is a thick pus coming out from the system, and then we can also place these Millicoat catheters. Cope catheter, it has a string, exists the catheter a few centimeters from the distal tip, and then re-enters the catheter near the tip. Pulling on the string forms a secure coil that is not easily dislodged from the renal pelvis. They range from 6 to 14 French, and they are used for drainage and installation of drug purpose and after percutaneous surgery. Other design is circle catheter. The circle nephrostomy tube requires two percutaneous access site to the when we are making more than one track during PCNL, then we can place this circle catheter. Its advantage is it's easily exchangeable, causes little trauma, rarely occludes, and provides excellent drainage. Previously, it was also used when there was a hematuria. It was used for irrigation of the upper urinary tract. Nephroureteral stent. They has a coil like that of a Cope nephrostomy tube, but the tube continues to the ureteral extension that travels down the ureter to end in a passive pigtail that rests in the bladder. So the advantage of these nephroureteral stent are that when we are planning for other setting in the same patient of PCNL, then we can place these nephroureteral stent. As this has extension into the ureter, we can pass guide wire and make easily track. We can make track from this so the patient doesn't need any other puncture. So we usually it's usually used when we are planning for another setting of PCNL in the same patient. Neliton catheter are also used as a percutaneous nephrostomy tube. So where do we use Neliton catheter as percutaneous nephrostomy tube? In which procedure we use Neliton? Yes, we use Neliton catheter as percutaneous nephrostomy tube in PCNL. So who will tell us about the steps of placing PCN?
So, which size of nephrostomy tube, that is the PCN, you will prefer to insert? The 6 FR, 8 FR, 10 FR, or the 14?
Technique when we use to get the access analysis. Any like for example in the SPC we can use the Seldinger technique. For the PCN placement we use the Seldinger technique. Is basically an access to the organ via the guide wire.
तो ये पंक्चर की टेक्निक नहीं है, ये पूरे प्रोसीजर की टेक्निक है कि गाइड
जी।
वायर के ऊपर आप जो है वो ट्यूब इंसर्शन करेंगे।
जी सर।
ठीक है, गाइड वायर, देन डायलिटेशन एंड देन placement of tube on that guide wire. This is not the technique of puncture.
Yes.
And other thing is that ultrasound to decide the percutaneous puncture site, and analgesia or anesthesia is also given after that ultrasound to pinpoint the area where you have to give local anesthetic. And local anesthetic will be given to skin and deeper nerves as well.
Yes. So
the choice of drainage tube is also important in Seldinger technique. Like if you want to use a Neliton catheter or the Foley's catheter after dilating the tract, it would be difficult to insert. But using a PCN with a trocar or without a trocar would be much easier in that context. Sir, it is a technique in which you puncture the organ, that could be bladder or abdominal cavity or the kidney, and after serial dilatation with a facial dilator, you insert it.
देखिए Seldinger technique is not that, because once you puncture an organ, for instance a kidney, pelvic system, but if that hollow needle hasn't got an apparatus through which you can place in something, then you can only suck some object, but you can't introduce another object. See, there has to be a two-way mechanism. For instance, you access the pelvic system with a needle that has got a kind of a B well, and with that you sort of go to an area where there is a fluid or a pus, and you check it whether you have entered the correct position or not, correct place or not. Then you remove the plunger, and through the back end of the needle you place in a guide wire. Now guide wire has got two ends. You have to tell us which end you want to place in, the floppy end or the straight end, right? If nobody is going to tell us all these things, then I'm sorry, it's not a technique. A technique has to be something which is related to SOP, standard operating procedure. If it is not a standard procedure and you are just telling us something with a kind of कहना चाहिए आप बिल्कुल ना कैजुअली बता रहे हैं, तो फिर तो बात बनेगी नहीं. आप एक थिएटर के अंदर एक लाइफ सेविंग प्रोसीजर कर रहे हैं, so everything should be very much clearer, right? So you enter the back end of the needle with the floppy end, and when the floppy end comes out of the tip of the needle, you have to know whether it has come out or not. How do you know it? Whether you measure the whole length of the needle, which is just inside, because maybe 1/3 or 2/3 of the needle is not in your vision. It is something which is hidden since you have punctured the flat surface of the abdomen or the flank, and the rest of the needle is just going in. आपको पता होना चाहिए कि आप वहां पहुंचे या नहीं पहुंचे. Now all these guide wires, they are also coated with some kind of a some kind of a material which you can see on a fluoroscope, right? Then you remove the needle. You leave the guide wire there. You insert through the guide wire another instrument which is called a dilator. You dilate serially. You dilate serially up to a point which is greater than 2 points above the actual diameter of the tube which you want to insert. For instance, आपने 6 French अगर insert करनी है, कोई मसला नहीं है, आपको 8 French तक dilate करना होगा. अगर आपको 8 French insert करनी है nephrostomy tube, तो आपको 10 French तक dilate करना होगा. So you have to tell all these steps one by one. ये कहना कि it's a technique by which you introduce a guide wire, so ये तो नहीं है, ये मानी नहीं जाएगी. इस तरह तो आप कहेंगे कि सेल्डिंगर टेक्निक से ना बहुत सारी चीजें जिसमें गाइड वायर इस्तेमाल होती है, तो गाइड वायर खो भी तो जाती है, वो क्या होगा, वो भी सेल्डिंगर टेक्निक. ऐसा नहीं करें भाई. तो आंसर प्रॉपर होना चाहिए. आंसर प्रॉपर होगा तो प्रॉपर नंबर मिलेंगे. छोटी सी चीज है तो इसके पूरे नंबर मिल सकते हैं आपको 10 out of 10. लेकिन अगर आपने इस तरह जवाब दिया तो फिर 10 out of 0 out of 10 मिलेंगे.
So steps are first inform consent, then give prophylactic antibiotics.
एक और थोड़ा सा टीजर का मतलब है कि तंग करने के लिए मैं पूछ लूं, ये जो गाइड वायर इस्तेमाल करते हैं इसको कहते क्या है, इसका असल नाम क्या है, कोई भी बता दे. रेजिडेंट पॉपुलेशन कोई भी बता दे, सीनियर जूनियर, नो प्रॉब्लम. नहीं पता, गाइड वायर का नाम नहीं मालूम. देखो, जिस बंदे ने इजाद की थी उसके नाम के साथ ये गाइड वायर मौजूद है, और उसने तो रेवोल्यूशन ले आया. अगर ये गाइड वायर ना होती ना कार्डियोलॉजी होती, ना इंटरवेंशनल कार्डियोलॉजी होती, ना जो है ना हम ये यूरोलॉजी की बातें कर रहे होते, तो वो तो उससे बड़ा एहसान तो किसी को हो ही नहीं सकता. तो आप अपने किसी मोहसिन का नाम तो याद रखें, उसका नाम है लर्नर क्वेस्ट. अच्छा, इस गाइड वायर की डायमीटर क्या है? कोई तो बता दे.
0.018 inches or 0.34 or 0.38 inches. 0.018, which we use in pediatric age group.
पॉइंट के बाद, डेसिमल पॉइंट के बाद क्या आ रहा है?
0.18.
ठीक, दो आती हैं, 0.035, 0.038. दोनों जो हैं वो लंडर क्वेस्ट गाइड वायर्स हैं. ठीक है.
So after giving the prophylactic antibiotics, we make the position of the patient. So in which position do we place the patient? Another position we can use for PCN placement. Yes, we can use a prone position, supine position, as well as lateral position. But we commonly use here prone position. So how do we place the patient in prone position? Dr. Jalal? Yes, we place 2 roll picks, one at underside the chest and other at the pelvic side, just below the iliac spine. So the abdominal contents will be fall down and we will avoid any collateral injury. So we use ultrasound, but there are other fluoroscopy can also be used to see the puncture site, and usually we puncture the most dilated calyx, but the posterior calyx is usually punctured. And what are the surface marking? Where should be the PCN placed? What are the surface marking for PCN placement? Thus, window should be above the inferior line.
जब भी आप लोग बोला करें ना तो एनाटॉमिकली करेक्ट पोजीशन बोला करें इन द
Anatomical.
मिड इन द मिड व्हाट मिड एक्सिलरी लाइन मिड क्लैविकुलर लाइन कौन सा लाइन किस किस लाइन की बात कर रही हैं पोस्टीरियर एक्सिलरी लाइन तो एग्री करते हैं सब लोग आप
Sir, can I add?
Boundaries.
देखिए यू आर ऑल सर्जन्स बाय एंड लार्ज चाहे 1 साल ले लें 2 साल ले लें 3 साल ले लें आप लोग सब सर्जन्स हैं खुदा के वास्ते एनाटमी तो सही तौर पे बता दें जी कोई बोल रहा था जी सकर जी जी
Sir, we place it in the renal angle, which is in the prone position. It is situated just below the last rib, the subcostal margin, medially, and lateral to the rectal spinal muscle, the lateral border of the rectal spinal muscle.
Right. So that is the renal angle, and I'm pretty sure that everybody knows it. And sometimes what happens is there is a mental block. Probably, if somebody like me is talking, then everybody stops thinking. So please don't do that because I'm not that kind of a fearful figure. आपको कम से कम ये सवाल के जवाब आने चाहिए तो इसमें क्या बुराई है ये है आंसर
So we then insert a guide wire and dilate the trach and insert the nephrostomy tube and fix it with stitch. So the complications of PCN are we commonly see hematuria, pain, sepsis, injury to the adjacent organs, extravasation of urine, catheter dislodgement, inability to remove nephrostomy tube due to crystallization. So, and the other part of our presentation are ureteral stent. So, ureteral stent are hollow tubes with a coil at each end and inserted through the bladder into the ureter, then into the renal pelvis. They have a coil at each end which prevent it from migration. So, the ideal stent should be easy to insert, ability to relieve intraluminal and extraluminal obstruction, excellent flow characteristics, resistant to incrustation and infection, chemically stable after implantation into a urinary environment, means it should be biocompatible and does not induce patient system, and it should have a good memory, so it cannot, when we remove the guide wire, so it makes coils. So what are the indications? The indications of placing a DJ stent are to relieve the ureteral obstruction. It could be intrinsic obstruction due to stone, tumor, or stricture, or extrinsic obstruction by compression by a tumor or overlying vessels, retroperitoneal fibrosis, or lymphadenitis. In urologic reconstructive surgery for splinting the ureter, in transplant, and in prophylactically before the gynecological or urological or abdominal surgeries to identify the ureter so we can prevent injury to the ureters. Okay, classification, and the DJ stents are classified on basis of material, length, size, and miscellaneous. So a material, we have biomaterials in which we have polymers, metallic, and biodegradable. In polymers, we have polyethylene. It was the first polymer, but the issue with it was it became brittle in the urinary medium, so it was prone to incrustation, blockage, and fragmentation. Silicon is the most biocompatible material. It has high friction coefficient and flexibility, due to which very difficult to navigate through a tortuous or obstructed ureter, and it has a poor tensile strength, susceptible for extrinsic compression. That's why it's not an ideal material for DJ stents. Other we have Percuflex, Soflex, and Cflex. They have made of property copolymers, softer and less bladder irritation. They are more biocompatible and can be left for longer time. Metallic stent, they are hollow and is a solid cylindrical stent for extrinsic compressions. They can be left for more than 12 months due to its low incrustation potential. Biodegradable, in biodegradable we have uripane DJ stent. which is made up of glycolic acid, polyethylene glycol, and barium sulfate. It can degrade inside the body in 2 to 3 months. So there is no need to remove the stent. So we can prevent, forgotten DJs. Is it? Memacoth they extend to predetermined size at warm water, which is 65 degrees centigrade, and they resist to incrustation. After placing these DJ stent, slightly warm water is introduced through passing a Neliton, so they can expand to a size. They are used mostly for variable length of stitches, benign and malignant. So other classification is based on length. Length of stent is the straight part of the stent and not from tip to tip. In pediatric age, in pediatric population, we calculate the length of the stent by age plus 10 centimeter. It's equal to the length which is required for that patient. An adult, which usually have a height of 149 centimeter to 179 centimeter, length of DJ varies from 22 centimeter to 26 centimeters. So can anyone tell what are the ways to calculate the length, roughly the length in adult population? Dr. Misal will tell us. Okay, Nadia. So simply we can decide for length on X-ray KUB from the Xiphi sternum to the pubic symphysis, and on intravenous urography from distance between the PU0 to VU0. Other is the classification based on size. So we measure the shaft. It represents the outer diameter of the stent, and usually it measures from 3 French to 8 French, and 1 French is equal to 0.33 millimeter. We have other stents, dangler stent. They are usually DJ with added nylon or proline wall loops dangling outside the stent. So they are helpful in removing the stent without use of scope. We can just pull the wire and the DJ will be out. And other is the endopilotomy stent. They are used after endopilotomy or endourological procedures of the upper ureter or proximal ureteric junction. Proximal end is wider with narrow distal end. So anyone can tell what are the complications of DJ stent? Dr. Nida will tell us. What are the complications of DJ placement? Yes. Other forgotten DJ. So these are the some of complications as told by Dr. Nida. Stent symptoms. Patient has lower urinary tract symptoms because the distal loop of the DJ irritates the trigone. So patient might have symptoms like increased frequency or maturation, bending maturation, and stent migration, urinary tract infection, because it's a foreign body which is placed inside the human being, so it's prone to urinary tract infection, incrustation if it's left for more time, and stent fracture, forgotten or neglected stents, which we commonly see in our setup. Patient come from a remote area, they usually have this type of complication. So whenever you place a DJ stent, you have to educate the patient that we have placed something inside your body, and you should have to come here again for it removal. So ureteral erosion or fistulization, inadequate relief of obstruction.
Just a word about complications. Two things. One is encrustation, and the other one is urinary tract infection. Now, there is always a question in everybody's mind that if a DJ stent is there in the system for a very long time and nobody knows how long that time is, maybe it is like 3 weeks, or it might be 3 months, or maybe 1 year, but there is no consensus on the time period. Perhaps it depends upon the bacterial load. If the causation is a urinary tract infection, but most of the cases of encrustation happens at those points of the stents where you see markings. You see, whenever you want to have a, if you see your any DJ stent, if you have got a picture, कोई है तस्वीर है डीजे की कोई? अच्छा, वो आप पहले दिखाई थी शायद. So if you go just यहीं पर रुक जाइए, यहीं पर रुक जाइए, यहीं पर रुक जाइए. So you see, this is if we just think that this is a piece of a DJ stent and not a piece of a PCN, then there are side holes, and also there are markings over it, so which are not seen in this picture. So what happens is these side holes are actually those areas where you, if you see microscopically in a model, when a DJ is in the system, then there is a lot of turbulence at these points, which are smaller holes on the sides. And these turbulent flows, they lead to kind of tornadoes. Tornadoes means के जैसे कि आपने देखा होगा कहीं पे समुद्री तूफान आता है, तो ये हर छोटा छोटा जो होल है ये अपने साथ इन रियलिटी छोटे छोटे तूफान लेके जो है ना चल रहा होता है. तो वहाँ पे जैसे यूरिन फ्लो हो रहा होता है, तो यहाँ पे जैसे जैसे वो करीब आता है इन होल्स के, उसके अंदर एजिटेशन पैदा होती है उस फ्लो में, और वहाँ पे वो थोड़ी सी स्पीड अप हो जाता है. वहाँ आप देखेंगे कि अगर उसको माइक्रोस्कोपिकली देखें और एक मोशन पिक्चर बनाएं, तो वहाँ पे आपको करंट्स मिलेंगे. करंट्स मीन्स कि वहाँ पे वेव्स मिलेंगी. वो एरियाज के जहाँ पे के मार्किंग्स होती हैं, दरअसल ये मार्किंग्स जो है ये पेंटेड मार्किंग्स हैं, और ये पेंट जो है ये भी सिलिका बेस्ड है. सिलिका मीन्स विच इज़ लाइक हैविंग सम काइंड ऑफ अर्थली मटेरियल. उसमें बहुत सारी चीज़ें हैं जो आपको पेंट के मटेरियल में मिलती हैं, जो कि हम घरों में दीवारों पे पेंट करते हैं. सो ये पेंट भी उसी किस्म का पेंट होता है जिसके ज़रिए आप मार्किंग्स करते हैं डीजे स्टैंड पे. ये जो मार्किंग्स की जो पॉइंट्स हैं और जो पेंटेड पॉइंट्स हैं, ये बन जाते हैं नाइडस, और उसके अराउंड जो है बाज स्टेंट्स के अंदर विद द पैसेज ऑफ टाइम स्टोन फॉर्मेशन हो जाती है, एनक्रस्टेशन हो जाती है, और वो फिर ग्रो करता है. एक तरीका तो ये है. दूसरा तरीका ये है कि इन्फेक्शन हो, ओवरवेलमिंग इन्फेक्शन हो. अब इन्फेक्शन के लिए ज़रूरी नहीं है कि वो किसी एक पॉइंट पे हो, लेकिन ये जितने भी पॉइंट्स होते हैं इन्फेक्शन के, ये इन साइड होल्स से हट के होते हैं. इसलिए कि इन साइड होल्स में एक तरह का इनबिल्ट मैकेनिज्म हो जाता है, जिसकी वजह से यूरिन खासा तेजी से फ्लो कर रहा होता है इनके पास, और कोई चीज़ इसी जगह पे डिपॉजिट नहीं हो पाती. सो अगर तो इन्फेक्शन है, ओवरवेलमिंग इन्फेक्शन है, तो वो कहीं पे भी एक बैक्टीरियल कंपोनेंट, एक नाइडस बनाएगा, एक न्यूक्लियस बनाएगा, उसके ऊपर एक बायोफिल्म होगी, एंड दैट बायोफिल्म will actually create a kind of the starting point of encrustation. So encrustation has got many different theories, but in the end they culminate into these two very important points. Those which are non-infective are actually at the marking points. Those which are infective can happen anywhere on the stent. It doesn't depend upon the length of stay of the stent inside the system, but rather it depends upon the actual patient and the actual metabolic as well as bacterial load of the urine which the patient is actually carrying or the system is carrying. So ये चीज़ें आजकल के ज़माने में याद रखिएगा. So अब जो स्टेंट्स आ रहे हैं और जो एक्सपेरिमेंट्स हुए हैं, वो impregnated होते हैं with some kind of an antibacterial property. They are impregnated with antibiotics, and these stents are available not in Pakistan but outside. So if you happen to place a DJ stent in a patient who is having a history of recurrent UTI, then these antibiotic impregnated stents are available for placement. If you have a practice in somewhere in Western Europe, there the biodegradable stents are available. And if you need a stent for a very shorter period of time, which may be like less than 6 weeks, then these biodegradable stents are available to you, but they are very costly and they haven't come to this part of the world. अच्छा, a word about Nalatin catheters. आपने शायद उसको miss किया है. Nalatin catheters now are available in the same form as it is shown here, but it is one is the coated hydrogel coated Nalatin catheter, and the other one is non-coated. The benefit of having a coated hydrogel coated Nalatin catheter is once it touches anything which is like a fluid having a water content, maybe urine, it becomes surrounded by a jelly-like material. And that jelly-like material will reduce the coefficient of friction. And the less the coefficient of friction, the less will be the chance of having a stricture, less will be the chance of having a trauma, and the greater will be the comfort experienced by the patient while you put in the Nalatin catheter. So आजकल जितने भी Nalatin catheter इस्तेमाल होते हैं वो हाइड्रोजेल कोटेड होते हैं. तो इससे पहले कि आप उनको पेशेंट के अंदर डालें, उसको पहले हम सेलाइन में या रनिंग वाटर, टैप वाटर में इवन और एक दफ़ा रन कर लेते हैं ताकि उसके ऊपर एक जेली जैसी बन जाती है और फिर उसको डालना आसान भी हो जाता है.
So, urothelial in pediatric population with complex lower urinary tract pathology, bladder valve syndrome, or with renal impairment or secondary VUGO, it is usually recommended to keep the child on drainage through ureterostomies. Loop ureterostomies are made to facilitate the upper tract drainage, as PCN has high risk for dislodgement and blockage. So, any question?
So in emergency setting, like in chronic obstruction, if patient presents to you with flank pain and sometimes if the patient have fever, so which type of drainage is more beneficial, has less in terms of less complication rate and a good quality of life? So what do you think that which type of drainage is important? The PCN drainage or the DJ stand, which has good quality of life? What we should choose? So how we will decide that the patient is having infection? If he does not have any fever, only flank pain, and you see on ultrasound that there is an obstructed kidney, what are the clinical signs and symptoms along with the documented evidence on the basis of ultrasound or labs? You will go for the type of drainage.
So on ultrasound, if you see there are echoes in the system, pelvic-calyceal system, or if the TLC of the patient is raised. So these are some signs that show infection, in which an internal drainage may harm him more than giving the benefit. So an external drainage like PCN is placed so that the system gets drained and the infection resolves.
So what would be the quality of life related to these stents, like the percutaneous drainage as well as the DJ stent, which has more good patient related comfort if we compare in terms of quality of life? Do you think that the PCN is a better option or the DJ is better option, and why?
I think the internal drainage is a better option for the patient because he doesn't have to hold on a bag along with him and take care of it. Whereas the PCN has a lot of problems. It causes skin erosions. It gets dislodged. The stitches get open, and the patient has to move around carrying a bag. But DJ stent also irritates the bladder. It causes dysuria and pain during voiding.
So yes, rightly stated, both have its merits as well as demerits, but as far as the documented evidence-based study concerned, so the percutaneous drainage has less infective complication than the endoscopic procedure, in which you have to do a retrograde study to confirm the tip of the open-ended catheter, that is the ureteric catheter. And in an obstructed system, especially where the urine stay for a longer time because of the obstruction and there is a overgrowth of bacteria, so there will be greater chances of infective complication, even the grade 5 Clavin mortality, comparable to the PCN drainage. But if we talk about the quality of life and if we compare with the bleeding complication, so it is less in the PCN, in the degestant population, the patients. So, sir, if you please want to add something.
Asha, like it or not, we live in a world where now personal impressions have got little value. For instance, you might find some of your colleagues saying that the biggest complication of today's urology is having a degestant, because once you place in a degestant, the patient goes away. Then when the patient comes back after, say, 1 year's time, then the kidney is gone because of encrustation of the stent. But you see, this is a problem which is like a logistic problem that can be solved, and it depends upon not the patient, but it depends upon the health system as well as on the doctor who is placing the stent. The second thing is the whole world has moved, the whole world of urology has moved in one direction, and that direction is minimally invasive surgery. Now, that direction was actually given way by the presence of earlier, as we have talked about in the earlier part today, by the presence of guide wire, and the second one is or was the DJ stent. Now, if stent wasn't there, mind you, all these URSs and upper tract ureteroscopies and RIRSs, you will not be able to do it, because then and then only you have got these kind of stents where you place them and you take rest so that the kidney can take rest, and all the trauma related to energy sources that you have been using in the system, within the system, can be absorbed and taken care of by nature. So stents have got a lot of value. Now, coming back to the question of whether it's a blessing in a third world, or is it something which is like having a complication of its own? There is no world as such in healthcare. It's all the same. It depends again on your own thinking. If you want to place in something, then you take responsibility. You take something called follow-up of the patient, responsibility of follow-up of the patient, and the patient will come to you again. But if you place in some stent inside and just leave it behind so that the patient will come when there is some complication, then again the things will not be the same as expected. So हर चीज को जो ना उसके वैल्यू पे देखना चाहिए. सिस्टम चाहे इन्फेक्टेड हो चाहे नॉन इन्फेक्टेड हो, डीजे स्टेंट डालने से इन्फेक्शन जो है ना ऐड नहीं हो रहा. डीजे स्टेंट इम्प्रॉपरली डालने से वो इन्फेक्शन ऐड हो सकता है. अगर पीसीएन भी आपने डाला किसी पेशेंट को, तो इसका ये मतलब नहीं है कि इन्फेक्शन ट्रीट हो गया, इसलिए कि पीसीएन इज अ ट्यूब विच इज ओपन टू एक्सटीरियर. You are actually providing an access to the kidney directly to the outer atmosphere. So if the atmosphere is infective, if the patient is in the hospital carrying the bag here and there and everywhere, the infection will be there and will not go away. So you won't expect something called external stenting is greater and beneficial as compared to internal stenting, because both have got their own values and both have got their own merits and demerits. So think about it. Maybe we can talk about these things later or through an article where both the things are actually compared head to head.
Thank you.
Thank you.